Thank you all for joining us this evening for a Prostate Conditions Education Council Education Series event. Tonight, we are honored to be joined by Dr. Carlton Barnswell from the Advanced Urology Centers of New York. Dr. Barnswell is a board-certified urologist practicing for more than 20 years. He graduated from the Yale University School of Medicine in 1988 and had residencies at Cabrini Medical Center and Mount Sinai. We are very thankful to have him join us tonight to ensure our patients understand prostate cancer and can be more empowered to manage their disease. You are welcome to submit questions throughout the webinar by utilizing the Q&A function at the bottom of your screen, and we will share them with Dr. Barnswell after his presentation and hope to answer as many as possible. And now, I am pleased to introduce Dr. Carlton Barnswell.
Good evening. Next slide, please. So what I'd like to do is to discuss the continuum of prostate cancer. Prostate cancer is a timeline. It's a sort of naturally progressive disease for some people. And the outcome for prostate cancer patients involves intricately the mechanism of hormone and the interaction with cells. So what I'd like to do is, in a clear way, talk about the natural course of prostate cancer and talk about the interaction of the hormones with prostate cancer cells and how it's involved in the progression. Next slide, please. So patients have different responses to their prostate cancer diagnosis. Some patients become very proactive and very involved in their care. Some become very practical and don't have a lot of emotions. Other patients are confused and they basically follow the doctor's orders. And some patients feel hopeless. Regardless of how patients feel, there are tremendous advances that have been made over the last few years that should provide opportunities for treatment and bring hope to patients and their family. Next slide, please. So what are the reasons for these different emotions regarding prostate cancer? So a lot of the feelings about prostate cancer relates to confusion about the stages and the treatment options and not really understanding what may happen in the future. There's also, as I mentioned earlier, a lack of understanding of what it means for people to progress from localized disease to what we call advanced or metastatic disease. Next slide, please. Next slide, please. So how big a problem is prostate cancer? So what we know about prostate cancer is that approximately 1 in 9 men will die from prostate cancer during his lifetime. And prostate cancer is the most common cancer that men are at risk for. Approximately 20% of the cancers in men are from the prostate. In addition, prostate cancer is the second leading cause of death in men. Next slide, please. So let's talk about the natural course of prostate cancer, what I referred to earlier as the natural history of prostate cancer. Next slide, please. So what we know about prostate cancer is that men who are diagnosed with prostate cancer and it's confined to the prostate or localized, they're treated what we call definitively, but some men after the definitive treatment will have a recurrence of their disease. And usually the first evidence of this is a rise in the PSA. I know many people are familiar with the PSA test. So the PSA test can be used as a screening tool to see if men are at risk for prostate cancer, but it can also be used to indicate that prostate cancer has recurred. So as this timeline shows, some men who develop a recurrence as evidenced by an increase in the PSA will develop metastatic disease. What I mean by that is when we take pictures or radiographic studies, we can see evidence of disease outside the prostate or where the prostate was. We also have a group of men who we don't see any evidence of any metastases, but we see their PSA rising. Ultimately, all of these men will develop metastatic disease and will require new treatment. Next slide, please. So, next slide, please. So, what are the sites for prostate cancer?
Dr. Barnswell.
So what are the sites for prostate cancer metastases? So the most common sites are bones, lymph nodes, and we can have also what's called visceral metastases or spread into soft tissue like the lungs and rarely in as far away as the brain. So it's important to for patients who fail therapy to be screened for metastases and to have a discussion about what this means in terms of treatment options and what those options are. Next slide, please. So what I'd like to do is to talk to you about an option that may help with some of the needs that we have for men who fail your definitive treatment when their disease is so-called localized and subsequently now have disease that's recurred. Next slide, please. So Erleada, or apalutamide, is a prescription medicine that's used for prostate cancer. It's used for men who have failed treatment and have metastatic disease after their failure. So in other words, they have evidence of a PSA elevation and we do x-rays and we see evidence of spread. So we can use the Erleada for patients who have metastatic disease that's recurred after their primary treatment. So there are also a group of men who failed therapy and we see no evidence of metastases. And we give them medication. As I said, hormones are intimately involved with prostate cancer. And when we give them treatment, they fail the initial course of treatment and your disease is progressing. So Erleada can also be used in that setting. Next slide, please. So let's summarize what I just said. So again, patients with localized disease, we try to treat definitively with their primary treatment, such as radiation or surgery. Some men subsequently will develop what we call biochemical recurrence. Their PSA will rise. And that's the first evidence that there is recurrent disease. In other words, their primary treatment failed. So there are two categories after this. So there's a group of people who have metastatic disease, and we can treat these patients by attempting to manipulate their hormones. And again, radiographic studies show that they have metastases. There's also a second group of men who we do radiographic studies and we see no evidence of metastases. And the primary treatment that we give them, which was to manipulate their hormones, as I said earlier, the hormones are intimately involved with prostate cancer growth. And in this second group, they failed that treatment and we don't see any evidence of metastases. So these are patients who have, who in the past had really no options available to them. And now we can consider these newer treatment options for. Next slide, please. So in men with prostate cancer that spread to other parts of the body, what we would like to see, what should be the goal if we have recurrent disease? The goal should be to reduce the risk of dying from prostate cancer and to reduce the risk of disease progression as well. So this new medication, which was the first medication approved by the FDA for these new categories of recurrent disease, Erleada, can be given to these patients, and it can result in a reduction of their risk of death, and then also in a risk of their disease progressing. And by disease progression, I mean developing further metastases. Next slide, please. So in men that have prostate cancer that has spread to other parts of their body, and we've given medication, as I said, we manipulate testosterone and the androgens in the body that can help the prostate cancer to progress. We manipulate that by giving medication to lower testosterone. And we'll also see a decline in the PSA. So in patients like this, when we give Erleada, in addition to that medication to lower testosterone, we see a decrease in the need for chemotherapy. Again, we're starting to see a pattern. We're seeing a pattern where in men who fail their primary treatment, we are reducing their risk of disease progression, as I said. What I mean by that is, again, disease progressing into other parts of the body. And also, we're trying to reduce their risk of death. We're also trying to reduce their need for chemotherapeutic intervention. So Erleada, in addition to the initial medication, will lower the risk for the use of chemotherapy as well. Again, all of these are the different things that we hope to achieve in these patients who have failed their primary treatment. We want to lower their need for chemotherapy. We want to lower their risk of disease progression. And we want to keep them alive longer. Next slide, please. So I want to reinforce this concept of disease progression. So what we see is initially we treat patients definitively with radiation or surgery. And in some of those patients, they fail their treatment. And in one group of patients with metastatic disease, we treat them with medications to lower the risk of their disease spreading to other parts of their body. So by giving the medications to lower testosterone, again, the hormonal therapy is important for prostate cancer progression. So we give them medication to lower their testosterone, and we can see also a decline in their PSA. When we add one of the newer medications, Erleada, we can get a better outcome. In the patients who we do x-rays and we don't see metastases and we give the medication to lower testosterone, eventually the PSA will start to rise again. And when these patients are called non-metastatic and they're so-called castrate resistant because they're not responding to that initial hormonal therapy that we gave. So in that category of patients, we can also give Erleada to improve all the things, all of those metrics that I mentioned earlier, the need for chemotherapy, trying to make them live longer and to decrease their disease from progressing. All of those metrics, that's our goal. That's what we want in these patients. Next slide, please. So how do we evaluate these patients in terms of time? So what we want to see is patients who have the new therapy. We want to compare them to a group of patients who only get the initial medication. We want to make sure that these men who has prostate cancer that has not spread to other parts of their body. So these are patients who have failed their primary treatment, but we have evidence that their disease has recurred because their PSA is rising. So in these patients, if we give them the initial medication to lower testosterone, if we give that medication by itself, what we see is that they don't do as well as the patients who get that medication plus Erleada. So Erleada plus the medication will delay the spread of cancer to other parts of the body or death by about 2 years compared to the other group. So again, the goal to do better, to delay the spread, we add Erleada, which will give more time. Next slide, please. So I alluded to this earlier. What are our goals? We want to make sure that the patients live longer, and we also want them to not progress. And when you compare the patients who get Erleada versus the group who did not, the placebo group, we see a significant change in the time to develop metastases and also the time for survival. We see the time to metastases is 40 months versus 16, and the time for disease progression is 40.5 months versus 14.7. So this is really showing the implications of adding this new medication to the standard medication, the one to just lower testosterone only. So we're seeing a significant improvement in all these metrics that we'd like to see for these patients who failed their primary treatment. Next slide, please. So again, what I just said was specifically for men that we've not had any evidence of metastases, but we know they've failed their primary treatment. Why? Because their PSA is rising after they've received their primary definitive therapy. So are there any concerns about using Erleada or apalutamide? We know that, as I said earlier, a few minutes ago, that we will get the benefit of decreasing the time increasing the time to metastases and also improving the overall progression of the disease. But are there any concerns to using the medication? So the patients should be advised by their physician that if there are any history, if there's any history of heart disease or seizure disorder, that should be something that should be considered. Also, Erleada may be associated with an increased risk of falls and fractures. So these are some of the side effects, again, that should be discussed. And patients that have risk factors, that should be a consideration when offering Erleada. Next slide, please. So what are some of the other side effects that we should talk about for patients who get Erleada? So one of the side effects that's fairly common is a feeling of tiredness or fatigue. There's also a risk of decreased appetite. There could be weight loss. There's a risk of getting a rash. The rash is not an allergic type rash. It's a rash that's seen in some patients, but it can be managed with just adjusting the dose in many cases. You can also have, as I said earlier, have a risk of falls and fractures, and you can also have hot flashes. You suddenly feel hot, and it usually will spontaneously resolve. There's also a risk of blood pressure elevation and diarrhea. All of these are potential side effects, not always seen in all patients, but these are all the different possible side effects that should be discussed with the patient before starting the therapy. Next slide, please. So let's talk some more about how androgens, specifically testosterone, interact and what role they play in prostate cancer progression. So what we know is the male hormone testosterone, it interacts with cells by binding to the cells. So if you look at the cartoon that we see here, the triangles are the testosterone molecules, and the purple is the outside of the cell, And you can see these triangles, these testosterone molecules that bind to these receptors, these positions on the outer portion of the cells. They then cross into the cells and go inside the center of the cell, the nucleus of the cell, and they interact with the DNA. So what we would like to do, because we know, as I said in the earlier part of the discussion, that these androgens, testosterone, they can help to propagate prostate cancer growth. Next slide, please. So what we would like to do is to suppress the production of testosterone and also try to interfere with the binding of the testosterone to the cell. This concept is called androgen deprivation therapy, or ADT. So what we would like to do is to lower the amount of testosterone that's available to bind to the cell, and again, prevent the testosterone from binding to the cell. This is the concept of androgen deprivation therapy. Next slide, please. So ERLEADA specifically will block the interaction of the testosterone to the cell. So as you can see here in the model, the green, the ERLEADA, it's in the position where the normal testosterone would bind to the receptor site on the cell. So by using ERLEADA to interrupt the interaction of testosterone to the cell, plus the other mechanism that is blocking the production of testosterone, we get a better outcome than just blocking the production of testosterone only. Next slide, please. So again, before taking ERLEADA, you should discuss with your healthcare provider if you have a history of heart disease, high blood pressure, diabetes. We also want to evaluate people who may have any evidence of elevated cholesterol or lipids, have a history of seizures. And of course, ERLEADA has no indication for people, for women, but it can cause harm, so it should be avoided in women who are pregnant. And men who have a partner who's pregnant or who may become pregnant, that should be a consideration also. Next slide, please. So it's important that you tell your healthcare provider about all the medications you take to make sure that ERLEADA does not interact with any of the medications that you're taking. You should also remember to tell them about any of your supplements or vitamins that you take, which are not provided by your doctor. Next slide, please. So how should you take ERLEADA? You should take it once a day. You should take the 4 pills. You should not break them in any way, and you can take it with or without food. You should, while taking ERLEADA, continue to take the medicine to lower the production of testosterone. Remember, from the models that I just showed, ERLEADA works by binding to the receptor site that testosterone binds to. It doesn't affect the production of testosterone, so you should continue taking the medicine that you're receiving to lower the production of testosterone. If you happen to overdose on your ERLEADA, you should immediately let your provider know or go to the emergency room. Next slide, please. So you should store the ERLEADA at room temperature. In the original package, there's a desiccant in the bottle to protect it from moisture. So you should keep that in and leave it in place. And you should protect ERLEADA from light and moisture. And of course, keep it out of the reach of children. Next slide, please. So again, take it exactly as we recommend that you take it 4 pills. Do not break them. If you have any side effects that you develop, you should tell your doctor. If there are side effects, call your doctor to discuss them. And don't stop or interrupt the therapy unless it's recommended by your doctor. Next slide, please. So the takeaway messages for today is Erleada is the first medication that was approved by the FDA for men who have prostate cancer that did not spread after after failure of their initial therapy. So specifically in men who failed their primary therapy, they were put on the medicine to lower testosterone. There's no evidence on radiographic studies of any metastases. And on the initial therapy to lower the testosterone, we start to see the PSA rise again. So in other words, the PSA is rising despite no metastases and the initial treatment to lower testosterone production. So in the past, men had no additional treatment available. And we subsequently developed for this space men without any evidence of metastases whose PSA is rising after they receive that primary treatment. Now we have Erleada available, and that medication is able to provide all the metrics that I discussed. We want to make sure that men can live longer, avoid the need for chemotherapy, avoid the progression of their disease, further metastases into their bones. And as I said, Erleada is now also approved for men who initially are presenting with metastases, and we can give it in conjunction with the ADT at the outset. So that's a new way we can use Erleada. Initially, it was just approved for people who had evidence of no metastases and had progressed on the primary treatment of testosterone production. So it's much more versatile now. You should continue to take the medicine to lower testosterone while you're taking Erleada, and you should be familiar with all the possible side effects, the fatigue, the rash, the risk of falls and fracture, the blood pressure effect. And also remember that you can get a sudden burst of hot flash, which is transient. And it's important that you become very familiar with all of these potential side effects, and you should report them to your doctor and your healthcare team so that we can better help. Next slide. So what are some of the questions that you may have for your doctor? Can you explain why prostate cancer has advanced? So specifically, in patients who fail their treatment and the PSA is rising, you may want to discuss where you are in terms of your disease progression. What does this mean? Do we have any evidence of metastases or not? What are my options available? If I have no evidence of metastases and I've gotten the medication to lower testosterone, again, to lower the production, and my PSA is rising, indicating that my disease is progressing, is Erleada an option for me? Or if I'm newly diagnosed with metastatic disease and I'll be prescribed the medication to lower testosterone, can I combine that with Erleada? So again, 2 uses for the Erleada. And can Erleada, for these 2 categories, help me in terms of the metrics that everyone wants to see? That is the risk of metastases or spreading, and delaying the metastases or spreading? And can it make me live longer? These are all the questions that we need to ask. And what about the side effects? What are the potential side effects? And what should I be familiar with in terms of risk factors? Do I have a history of seizure disorder? Or am I at risk for falling or having fractures? Do I have a history of hypertension? So those are some of the things that we should be familiar with so that we can have a discussion with our provider. Of course, ERLEADA patients who qualify for it may get financial assistance, so you may discuss what type of assistance is available. Next slide, please. So there are a lot of resources that are available for men with advanced prostate cancer and prostate cancer in general. Please become familiar with all the different organizations. My group in New York here, partnered with many of the groups you see listed here. It's ongoing, and a lot of these organizations provide a lot of information and support, and these are wonderful tools for patients with prostate cancer, and they provide a lot of information for patients as well as support. Next slide, please. So I thank you very much for your attention. I hope the information I provided was of benefit. Please let us know if there are any questions.
Thank you, Dr. Barnswell. Yeah, we do have a couple of great questions here. I'll go ahead and read those for you. First one is, does ERLEADA have different benefits based on race?
So that's an excellent question. So we don't have any data to suggest that. The reason why that question is important is we know that some men are more at risk to develop prostate cancer, specifically, as many people may or may not know, African-American men and men from the Caribbean have a higher risk of developing prostate cancer. Additionally, there are patients who have a family history of prostate cancer and may have a genetic predisposition to prostate cancer. However, we have no data to suggest that there's any benefit based on race. The data, when you look at the metrics that we use, that is the risk of disease progression, delay in metastases, and recent data that has been presented now with survival, all of those it's very compelling that when you combine ERLEADA for those two categories, for the men who have disease that failed their treatment, they have no evidence of metastases, and we've given them the medicine to lower testosterone. In the past, as I said, we had no options, but now we can add ERLEADA to that medicine that they're taking, and those men will all get the benefit of delaying the disease progression, delaying metastases, decreasing the need for chemotherapy. Second, men that have metastatic disease that we're going to start on the medicine to lower testosterone, we can now also add ERLEADA. So in a sense, the men that are at the very outset of failing their primary treatment, who have metastases, we can now add ERLEADA to the medication that's just going to lower their testosterone. So two sort of separate categories where we see benefit from both, but it's not based on race. And again, the metrics are very compelling in terms of the benefit.
Thank you very much. We have another good question. Why do you stay on androgen deprivation therapy like Lupron when PSA starts to rise? When you also add anti-androgen like ERLEADA, why don't you just switch medicines?
So that's an excellent question. So what we know is that, again, just to go back to some of the pathophysiology, the basics, the mechanism completely different. The Lupron and the Leuprolide, the ERLEADA, all of those medications, they lower the production of testosterone. The ERLEADA interrupts the interaction of testosterone with the cells. So by combining both, you get both benefits. So we did not study the Erlita without the combination. But with the combination, the evidence that we have that's been published is that the Erlita plus the medicine versus the Erlita. I'm sorry, versus the Erlita plus the medicine versus the Leuprolide or Erlita. I'm sorry, Eligard. Those are all the same medications that we give long-term to lower the production of testosterone. So Erlita plus those medicines is better than the medicines alone. Very important point. So that's why we continue. It's good because the evidence is very compelling. Again, I didn't want to get lost in the numbers, but you saw those very substantial changes in the number of months for blocking disease progression from significantly over a significant amount of time, from 40 versus 16 months and 40 versus 14 months. Again, combining the medicine to lower the production plus Erlita is better than the medicine to just lower production alone. Very, very compelling data.
Thank you. That was a very good explanation. The last question I have, it says, what scans or imaging should you have done to look for metastatic prostate cancer when your PSA is starting to rise?
Excellent question. And this is an area that's evolving. So initially, in the past, we used CAT scan or MRI combined with a bone scan. So the CAT scan or MRI looks better at soft tissue. Remember, I mentioned the sort of visceral mets, the metastases into lymph nodes or into the liver or the soft tissue. So the CAT scan and MRI was used for that purpose. And then we combined it with a bone scan, which specifically looked for metastases in bone. So where we are today is there are newer studies that are evolving. And again, this is evolving, where we can find better, which are better at detecting recurrent prostate cancer. There's a test called an Axumin scan, and there's a new study that may be available in the near future called a PSMA scan. So let me just talk about the Axumin scan because that is currently available in some parts of the country. So what we do with that scan is we take a small chain of amino acids, which is building blocks for protein, that preferentially goes through channels in prostate cancer cells. So what we do is we put a marker on that chain of amino acid that preferentially gets taken up by prostate cancer. So if you will, we attach something to a chain of amino acids that light up, and we inject it into the patient, and then this travels all over the body and then preferentially goes into areas where there's prostate cancer present. So this Axumin scan may be available in some parts of the country. So the advice in terms of looking for a recurrent disease by your doctor could involve doing a CAT scan and bone scan, or CAT scan MRI. I'm sorry, CAT scan or MRI combined with a bone scan. Again, usually in most places we do a CAT scan and a bone scan. But that again is now may not be as sensitive as some of the newer studies with this new Axumin scan, which, as I said, has a molecule that preferentially goes through those channels in the prostate cancer cell and lights up. So the Axumin scan is one option versus doing a bone scan combined with a CAT scan, or a bone scan combined with an MRI. Much more common is the CAT scan and bone scan, which now, as we look on the horizon, that may become less of an option as we get these better, more sensitive studies, including this Axumin scan. And as I said, in the future, we may have a newer study, even more effective than the Axumin scan, called a PSMA scan, which will be available in the future. So that also was an excellent question.
Well, thank you. Thank you again for that very educational discussion, Dr. Barnswell. We greatly appreciate your time. We also want to thank our sponsor, Janssen, for making this program possible. And for anyone who joined late, you will be able to listen to this webinar in its entirety on the PCEC website at prostateevents.org. And Thank you so much again, Dr. Barnswell. We really appreciate it.
My pleasure. Thank you so much for inviting me.
Have a good night.
Have a good night.